Okay, thank you so much, everybody, for joining and spending your evening with me. As I said, this webinar will be recorded, and if you have signed up via email, it will be getting sent out to you. Today, we're going to be discussing a deep dive into PCOS and nutrition. Just to start off with a disclaimer that this presentation is not a substitute for medical advice and is intended for educational purposes only. And we will be touching a little bit on infertility and fertility issues. So obviously it's online. Please feel free to excuse yourself. And as I said, it's recorded, so you can always come back to it. And if you do need any further support, we have fertility counsellors on board at Hertility if you need to speak to somebody. So my name is Emily. I am Hertility's fertility nurse and clinical nutritional practitioner. I work as both a nutritionist and a fertility nurse at Hertility. I specialise in women's health. I have previously worked in gynae and surgical settings within the NHS and private hospitals. I've also worked in an NHS fertility clinic. I have a master's degree in clinical nutrition and public health from UCL. And I'm also a trained nutrition counsellor, which means that I focus on health promoting behaviours, empowering people to improve their relationship with food and their body, and coming at it from a non-diet angle, which we will discuss a little bit today. And yeah, as I said, I specialize in women's health and fertility. So it's helping people manage symptoms, whether it be PCOS related or trying to optimize fertility. So we are going to cover today, what is PCOS? So hopefully you'll have a good understanding by the end of it, what PCOS is, how does it impact on fertility, how can you manage PCOS through diet and lifestyle. We are going to be taking a look at the new international guidelines, which I'll explain a bit more about in a moment. What is the best diet for PCOS? And also I will touch on supplements throughout the webinar. So hopefully you'll have a good understanding at the end. As I said, there is a Q&A box, so please feel free just to pop in questions and I will try my best to answer everything at the end. So firstly, what is PCOS? So just looking at PCOS prevalence, we know that it affects 1 in 10 women within the UK. 70% of cases of PCOS remain undiagnosed worldwide. It can take up to 2 years to receive a diagnosis for PCOS. PCOS is known to be 2 times more prevalent in South Asian women. 11% of Hertility users report having PCOS, so that's over 30,000 of our users. And additionally, people may have to see up to 3 different doctors to receive a diagnosis. So what is polycystic ovary syndrome? Well, it's a syndrome, which means it's a collection of symptoms. It's one of the most common endocrine disorders affecting women of reproductive age. And to receive a diagnosis of PCOS, you have to have 2 out of the 3 of this diagnostic criteria, which I will go into. But those 3 are polycystic ovaries, irregular periods, or hyperandrogenism. And because it affects the endocrine system, which essentially is our hormones, it can have an impact on various different areas. So thinking about skin, mental health, period-related problems, skin-related issues, and weight-related issues. So getting a diagnosis then. So just to introduce you to the new and updated guidelines, I am going to touch upon these quite often throughout the webinar. I think it's really important for you, if you have PCOS or you suspect that you have PCOS, to make sure that you're up to date with these new guidelines. So they are based on something called the Rotterdam criteria. And Rotterdam criteria is a diagnostic tool used to diagnose PCOS, and it's certainly what we follow here within the UK in terms of our practitioners, and in many other countries as well. And these guidelines are based on that, and they have been revised as of August 2023, so this year. They are based on the guidelines have been published via the American Society for Reproductive Medicine. So I am going to touch on those quite a bit. So you're welcome to go and view those after, but hopefully I can give you quite a good understanding of them. I do think that the new guidelines that they have published can be really beneficial. So yeah, we're going to go into those throughout the webinar. So in terms of receiving a diagnosis for PCOS, as I said, there is this diagnostic criteria, and you have to meet 2 out of the 3 of this diagnostic criteria to reach a diagnosis. And so the 3 are a history of irregular periods or no periods at all, increased androgen levels, so hyperandrogenism, and this can be confirmed either by a hormone blood test or by having physical characteristics or symptoms, and then evidence of polycystic ovaries. And so this is where it gets interesting now, because this is one of the revised updates. So before, in terms of diagnosing polycystic ovaries, we could only go by a transvaginal ultrasound scan or an abdominal scan in some situations. But now at the last meeting in 2018, they brought up that in fact AMH is an important marker in terms of diagnosis, and now it's actually been recommended that we can go off of AMH in terms of diagnosing polycystic ovaries for PCOS. This is really promising because it means that in not all instances do you have to then be referred and go and have a transvaginal ultrasound scan. You can just do it off of a blood test. And conveniently, that means that you can get a diagnosis off of a fertility test. So we test your androgens, we test your AMH levels, and we also get a good history from you beforehand, so we know if you've got irregular or missing cycles. In terms of polycystic ovaries, like I said, it can either now be diagnosed via a transvaginal ultrasound scan or via an AMH or an anti-Müllerian hormone. So I'm just going to go into each of those. So in terms of polycystic ovaries on an ultrasound scan, this is what they tend to look like. So often it can be described as a string of pearls, and this is a normal ovary here. So you'll just see that there are lots more follicles on the ovaries. And the follicles are these fluid-filled sacs which your eggs will grow inside. And essentially what we would do is count the amount of follicles that we can see on your ovaries in terms of making a diagnosis. So the other way that we can assess polycystic ovaries is via AMH. So anti-Müllerian hormone. So it's the hormone that's given off by the follicles within your ovaries. And like I said, it's the follicles that are these fluid-filled sacs which your eggs grow inside. Because you only need to have 2 out of the 3 to get this diagnosis of PCOS, potentially it could be that you've got the irregular cycles and the hyperandrogenism, and therefore you don't have the indication that you've got polycystic ovaries. And so if you were to take an AMH test, the way that it would be presented to you is either within range, high for your age, or whether it was considered low. So if it comes back as high, then it's likely indicating that you've got polycystic ovaries, because you've got this high amount of follicles there giving off high amounts of AMH that's then detected in the blood. Or potentially it could come back that it's within range and where we would expect it to be for somebody within your age group, or potentially it could be low. And if it were to be within range or on the lower side, then it gives us an indication of kind of what your egg reserve is based on your age, essentially. In terms of a diagnosis for adolescents, it's not recommended that we use AMH or polycystic ovaries on an ultrasound scan to diagnose PCOS. So we can only go off of hyperandrogenism and missing or irregular cycles. And that's just because generally when you're younger as well, naturally you're going to have a very large amount of follicles because you're young and you've got lots of eggs. So it would be difficult to use that as a diagnosis. So irregular periods then. So unfortunately, it can be caused again due to these hormones, so either high levels of testosterone or potentially high levels of luteinizing hormone. So whilst it doesn't constitute towards an official diagnosis in terms of the hormonal range, we often will see that people with PCOS have a high luteinizing hormone, and we'll see quite often see a higher luteinizing hormone to follicle stimulating hormone ratio. Luteinizing hormone is the hormone that triggers ovulation. So obviously, if you're having irregular cycles, that might be that there is a disruption there to your ovulation. And so essentially, it just disrupts the follicular development. So follicle stimulating hormone is the hormone that matures the follicles at the start of the cycle. So if there is a disruption going on here with the cycling hormones, it just means that your eggs can't mature properly. So they don't grow to the stage of maturity that we would want them to then be able to become large enough essentially to then ovulate. So instead they kind of get stuck at this stage of immaturity and sort of group on the ovaries. So that's why you can see it on the ultrasound scan. In terms of what we class as irregular, I do think this is really important, because I do find that lots of people firstly get confused between the difference in their actual period as opposed to the whole menstrual cycle. And it's really important for us as practitioners to know that information so that we can establish whether we consider your cycle to be regular or irregular. And it's good for you to know. So anything under 21 days is classed as irregular. Anything over 35 days is classed as irregular. And it would be really common in PCOS for people to have those long cycles. So generally it tends to be like kind of around the 40-day mark, or lots of people don't experience periods at all. It is really important to have some periods. So if you're not on hormonal contraception, so the guidelines are that you should be having more than 4 periods per year if you're not on hormonal contraception. If you're on hormonal contraception, it's already kind of suppressing those hormones so that you don't get this buildup of cells within the endometrium. But that's the reason that we want you to have a period if you're not on hormonal contraception, is so that you can shed those cells so you don't get an abnormal buildup. So I can just see someone raising their hand, but I am going to take questions at the end, if that's okay. Unless you can't hear me or see something, I'm just going to check. Okay, fine. Oh, okay, now I can't hide the box. Okay, we're back. Okay, so the other one, so we've spoken about irregular periods and polycystic ovaries. So the last one is hyperandrogenism. So with hyperandrogenism, it means high androgens, and it can either be biochemical, i.e. it shows up in a blood test, or it can be physical or clinical symptoms of hyperandrogenism. So in terms of hyperandrogenism, what we're looking for is if you were to go and take a test, for example, a Hertility test, and we'd be testing your androgens for you, we would be specifically looking at these hormones here. So testosterone and DHEA are androgens, and sex hormone binding globulin, or SHBG, is a globulin or a protein, and it binds to estradiol and testosterone. So often we will see if you have got hyperandrogenism biochemically, we will see either a high testosterone, we might see a low SHBG, and we might see a high DHEA. What often happens when you get either a high or a within range testosterone is that you end up with this low SHBG level. And it's just because it generally binds to testosterone. If there's too much free testosterone circulating in the blood, it can't quite do its job very efficiently. So you end up with these low levels, and that can contribute towards symptoms. In females, we do want some amount of testosterone, but we don't want too much, because it then can have a knock-on effect to your menstrual cycles and insulin resistance. And likewise, DHEA, as I mentioned, is an androgen, and it gets converted into testosterone, so again can contribute towards some of those symptoms. In terms of clinical hyperandrogenism, so for some people with PCOS, they will have the biochemical and they will have the clinical hyperandrogenism, i.e. the symptoms. Some people will just have clinical, and some people will just have biochemical, and some will have both, which is why it's really individualistic when it comes to PCOS. And someone actually asked me if there was kind of a severity or a scale when it comes to PCOS. And we don't have one, like we don't grade it like we do in things like endometriosis, but we do have different phenotypes, and that's the different collection of symptoms that you have. So somebody might have irregular cycles, polycystic ovaries, and then they may have hyperandrogenism, and it might be clinical and biochemical, whereas somebody else might just have perhaps acne, which is just clinical hyperandrogenism, and maybe polycystic ovaries, for example. So it might be a little bit milder in the sense that they're only experiencing acne, where somebody else could literally just have every symptom, which is why it's really important to understand that and kind of know what collection of symptoms you have specific to you, because then it can help with the management. So the physical signs to look out for are hair-related issues. So thinking about hirsutism, so excess hair growth, which usually will occur on the face, the chest, or the back. And then hair thinning and hair loss from the head, so male pattern baldness or alopecia. And then skin-related issues. So you may get oily skin, acne, or dark velvety skin patches. So in terms of insulin resistance then, so there is a link with insulin resistance and PCOS. So we know that people with PCOS are at an increased risk of having insulin resistance, and it can occur in around 80% of people with PCOS, and that is regardless of BMI. So it can occur due to an increase in those androgens that we discussed, and then it can reduce our sensitivity to insulin. So when you eat carbohydrates, in order to compensate, your body produces more insulin. And when you have got some kind of degree of insulin resistance there, your body's not working as efficiently as it should do, and then your body tries to increase the amount of insulin that is produced, and then this contributes again to an increase in the androgens, for example, an increase in testosterone. So it's a bit of a vicious cycle. Having high insulin levels or hyperinsulinemia is linked to miscarriage, reduced chances of implantation, and also oxidative stress. So essentially contributing towards inflammation in the body. And it can also cause food cravings, increases in appetite, and drive weight gain. And it's when we start to get that weight gain around the middle that then starts to increase our risk of long-term associated conditions with PCOS, so things like type 2 diabetes and metabolic disease. So PCOS is really complex, and it can have a knock-on effect to all of these different things going on here in terms of physical health, mental health, and then the symptoms that come along with it. So we are going to discuss each of those and how you can manage it through diet and lifestyle factors. In terms of management options, there are options of having hormonal contraception or medication. I'm not going to go into those. I'm going to focus more on the diet and lifestyle and fertility support. However, I do find often that people are a bit apprehensive when they're recommended to go on hormonal contraception as a treatment for PCOS, which is completely fair enough if you don't want to take the hormones. However, it is a good option in terms of treatment for PCOS. Like I said, it can be helpful in terms of helping to shed that endometrium, so the lining of the uterus. And it can be helpful if you're experiencing heavy periods. And some hormonal contraceptions are anti-androgenic as well, so they can help with those symptoms like acne. So I definitely think it's something not to rule out and potentially discuss with the doctor as an option. And then there's also medication as well. So there are anti-androgenic medications, which might be explored as a kind of last line if you've explored other options and they've not worked. But things like metformin are often prescribed for people with PCOS, and that's generally if you've got insulin resistance, so it can help with that, but also regulating cycles as well. So I'm going to be touching on the lifestyle side of things. So again, I'm just quoting from these evidence-based guidelines, and I'm quoting quoting these because I think that what they've recommended now, specifically in terms of diet, is really useful to know, because they are basically saying that there isn't one type of diet that will benefit PCOS. And actually, it is about eating within population guidelines. So this is the healthy eating guide from our government within the UK, but it should be sustainable and it should be tailored to each individual person, to their preferences and their goals, which is really important because, as we've seen, people with PCOS have very different collections of symptoms, and there are specific foods and different dietary practices and exercises that can specifically help target those specific symptoms. And they also say that it should be flexible and avoiding unduly restrictive and nutritionally unbalanced diets, which is really important and something I wholeheartedly agree with. I don't think it should be restrictive. I think it should be what can you add in as opposed to what can you take out of your diet. So here are some common, very common PCOS dietary myths that I hear a lot. And definitely something when people come to me for nutrition consultations, it's definitely one thing that I hear a lot, is that there's a lot of misinformation out there online, which you'll definitely see. And if you're on social media and things like that, there's a lot of conflicting advice. And these are three very, very common ones that come up. So the first one is you have to cut out dairy. So there is not enough evidence to support this currently in terms of PCOS. So in terms of the evidence, there neither high fat, low fat, or fermented dairy consumption has been shown to increase inflammation in PCOS. And actually, interestingly, some research has shown that it can, especially full fat dairy, can actually have an anti-inflammatory effect, although the reason is not exactly known why. There is some research on acne and dairy intake, and showing that fat-free or low-fat dairy foods can potentially exacerbate acne symptoms. But important to note that that study wasn't specifically done within people with PCOS. It was just in an average population. So this is the thing, you have to take all of these things with a pinch of salt and kind of dig a bit deeper. You have to cut out gluten, another one I hear. There isn't any scientific evidence to back this up, unless you've got a medical reason, such as you've got gluten intolerance or you've got celiac disease, then in which case, obviously it'd be warranted, but there isn't enough evidence to support cutting out gluten. The other one is low carb as well. So in terms of low carbohydrates specifically, when there are lots of studies in this area, but they have very small participant numbers, and they also have very high dropout rates, which means that the diets are really hard to stick to, hence why they're dropping out of the studies, because they're just not sustainable. Carbohydrates are super important for energy levels for a start. I'm sure if anybody's ever tried going low carb or keto or anything like that, then you tend to feel pretty tired and a bit crap and can get things like brain fog. So and carbohydrates are really important. So they're important for specifically thinking about fertility and reproductive function, as is said, as well as providing energy and also key nutrients as well. So it's more about the quality of the carbohydrate as opposed to the quantity. So we will just go into that now. So what is the optimum diet when it comes to PCOS? So the main thing that we want to be looking at is building a balanced plate. So thinking about each of the key macronutrients, so carbohydrates, protein, and healthy fats. So each time you're building a plate, it's important to think about, and not even just a plate, thinking about snacks as well. When you're having a carbohydrate, having it with some protein or some fat to slow the absorption, so that you're kind of getting a nice steady release throughout the day, as opposed to getting a spike in your blood sugars. So that's kind of what we're aiming for. And when I was talking about the carbohydrate, we want to be aiming for high fiber carbohydrates, again, so that the absorption is slowed in terms of the glucose into your bloodstream, and then focusing on low glycemic index foods or low GI foods. So again, it's the whole grain varieties of carbohydrates, so things like oats, quinoa, brown rice, brown pasta, brown noodles, and then in terms of other low GI foods, so things like fruit and vegetables, chickpeas, beans, and lentils. And then your high GI foods, which are more likely to spike your blood sugars, are your things like your white rice and white bread, cakes and pastries, things like that, and your sugary drinks. Protein is very satiating, so it's going to help you fill up, but again, helps to slow the absorption of that food. So it's a really good idea to make sure that you're getting some good quality protein within there as well. And then some healthy unsaturated fats as well. So saturated fats are the fats that you're going to get in things like cakes and biscuits. And then your healthy unsaturated fats are your mono and your polyunsaturated fats that we get from things like oily fish, olive oil, nuts and seeds, rapeseed oil, and avocados. In terms of lifestyle advice specific for ovulatory infertility, i.e. not ovulating, there was a study from 2007 that looked at 17,000 women, and they found in this study that making 5 or more dietary and lifestyle changes resulted in almost a 70% lower risk of ovulatory infertility, which is really huge. And these are some of the recommendations from that study. So again, focusing on these good quality, low GI carbohydrates, focusing on full fat milk. Interestingly, I wonder if it has a link to do with the anti-inflammatory properties that we spoke about a moment ago. Healthy fats, healthy fats are very important in terms of our hormone health, but also helping to absorb fat-soluble vitamins. And again, then thinking about multivitamin use as well. So often people with PCOS will have or are more susceptible to having micronutrient deficiency, so things like zinc and magnesium and vitamin D. So it may be that the multivitamin use was helping to kind of replace some of those vitamins where they were falling short. And then intake of plant-based proteins. Plant-based proteins are really important for female fertility as well. In addition to that, in separate research, we know, well, anecdotally, but also from the research, that regular exercise really helps to regulate menstrual cycles and therefore having a positive effect on ovulation. I definitely notice it with a lot of my clients where they say that kind of in the winter period when it's a bit colder and they're not really exercising so much, that they find that their cycle length kind of gets longer again, the cycle is a bit more irregular, whereas in the summer when they're a lot more active, they do find that their periods are a bit more regular. Interestingly, cinnamon extract, so there is a small bit of research showing that cinnamon extract may help with menstrual cyclicity. If you like cinnamon, then why not try it? There's no harm in it. The evidence suggests 1 to 2 teaspoons per day. So if you're having a porridge or a smoothie or something like that, might be worthwhile adding it in there if you do enjoy the taste. And then another one is inositol. If you've got PCOS, you've likely heard of inositol. It's a vitamin-like substance. It's an insulin sensitizing agent. It basically will help with from a metabolic perspective, but also, and then I think that's where it then has a positive effect in terms of your menstrual cycle. So we have new and emerging research in terms of inositol specifically looking at PCOS. It naturally occurs within the body anyway in foods such as things like beans. For around 30% of people, they will be resistant to it, so it won't necessarily work. And it's difficult to say whether especially if you are making other dietary changes at the same time, it can be difficult to pinpoint if it is working for you or not. But it tends to have minimal side effects. As I said, it's naturally occurring within the body anyway. So if you have got PCOS and potentially, have got irregular cycles, or hyperandrogenism, or suffering with metabolic consequences, then it could be worthwhile giving it a go. It can take around 3 to 6 months to see the benefits of it as well. So it's kind of something that you have to persevere with. So I mentioned that if you have PCOS, you are at an increased risk of things like metabolic disease, high cholesterol, high blood pressure, type 2 diabetes, unfortunately. So it is really important just to think about looking after your metabolic health. And so there's a few ways in which you can do that from a lifestyle perspective. So thinking about heart healthy diet, so Mediterranean style diet kind of comes up on top in terms of looking after our heart health, but also it's beneficial in terms of fertility and also for PCOS. If you have got something like high blood pressure, then likely you may have been recommended something like the DASH diet anyway, which can, is a heart healthy diet. Magnesium that can be beneficial for insulin levels and blood pressure, and levels will often be low in people with PCOS. I mentioned before about inositol being beneficial in terms of metabolic profile. Chromium, you will often find chromium comes in an inositol supplement, but again, it can help from a metabolic health perspective with blood glucose control and insulin levels. Coenzyme Q10, this is kind of an emerging area of research. So coenzyme Q10 is a powerful antioxidant. And in terms of PCOS, it may have beneficial effects on glucose metabolism and cholesterol. And if you are over the age of 35 and you are trying to conceive as well, it may be beneficial in terms of the egg quality as well, because after the age of 35, it's when the quality of our eggs starts to decline. So it can be beneficial for both PCOS and fertility. Vitamin D levels. So quite often, as I mentioned, vitamin D can be low in people with PCOS. So it could be worthwhile if you suspect that you might have low vitamin D levels, making sure that you go and get it checked. But definitely, we're coming up to kind of darker weather now as well, so it's really important anyway for all of us to be supplementing with 10 micrograms a day of vitamin D, especially if you have got PCOS. It is something to consider. Again, cinnamon extract may improve insulin resistance. Symbiotics, so symbiotics are a mixture of prebiotics and probiotics together, and there is some evidence to suggest that it could reduce the risk of type 2 diabetes. And we know that people with PCOS tend to have less favorable gut bacteria anyway. So I always recommend to my clients, if you have got PCOS, to try and look after your gut health as well. Just because there is a bit of a link there with your metabolic health, and also things like mood as well. And then so also thinking about optimizing sleep, managing stress, and regular movement in terms of metabolic health. So if you have got hyperandrogenism, so whether it's the biochemical or the clinical hyperandrogenism, there is some research here, which I'm going to go through now, which can help to either improve the SHBG levels, because we want those to be within range rather on the lower side, and testosterone levels so that they come back within range as opposed to being on the higher side. So in terms of the research and lowering your testosterone levels, omega-3 supplementation may help to lower testosterone levels. There is so much evidence now for omega-3s in terms of PCOS, and specifically looking at fertility as well. So omega-3s we find from oily fish, so salmon, trout, herring, anchovies, mackerel, sardines. The recommended intake is 1 to 2 portions per week, so, and a portion to be 140 grams of cooked oily fish. And if you don't eat oily fish, then it could be worthwhile looking at a supplement for PCOS. It can help to reduce levels of inflammation, as well as decreasing those testosterone levels. So if you do like oily fish, it's really good to get it from food in the first instance. However, yeah, as I said, if you don't eat oily fish, then obviously you can look at supplementation. And you would just want to go for the same dose that you would get from having the 1 to 2 portions per week. So a 450 milligrams of EPA and DHA. And then we also have some evidence that drinking spearmint tea may be able to reduce testosterone levels. I have heard anecdotally that it maybe tastes a little bit funny. Some people don't like it, some people don't mind it. Obviously, I think it's no point drinking a cup of tea if you don't enjoy it, but if you do enjoy it and you can get hold of it, because it can be a little bit hard to get hold of, then yeah, there is a randomized control trial, which has been shown to reduce those levels. Also a small amount of evidence showing the benefits of flax seeds. Flax seeds also contain omega-3s, and they've been shown to lower testosterone levels. Again, there's no harm in taking them. They're beneficial for your overall health anyway. Rich in fiber, they can help with your gut. And you can add them to things like smoothies and stuff and not know that they're there. So again, something to potentially try that, doesn't come with a huge price tag as well, or any side effects. Maybe just helping you go to the toilet. Strength and resistance training has also been linked to reduced testosterone levels, also yoga as well. So I do often recommend people with high androgens as well, just to potentially give those things a go if they do enjoy those. Just with strength training as well, it's so beneficial for a metabolic health. And also, if you have got high testosterone levels, you may find that you I guess eventually might enjoy weight training as well, because you may find that you can lift heavier weights than your peers. In terms of positively affecting your SHBG levels, there's evidence showing almonds and walnuts specifically have beneficial effects on androgens, so SHBG levels, but also free androgen index, which is free testosterone and SHBG combined. Protein is really important for androgen levels, and some evidence suggests that it can help to increase SHBG levels. So hopefully you're getting those good quality protein sources in anyway, with each of those meals and snacks. Again, looking at symbiotics and probiotics seems to improve SHBG levels and inflammation in people with PCOS. And again, regular exercise can help to increase your SHBG levels. So just a bit of a spotlight on mental health then. So this is a quote from those guidelines, from the updated guidelines. So healthcare professionals should screen for anxiety and depression in all adults and adolescents with PCOS. This is a really important area because the symptoms associated with PCOS can contribute to people being 5 times more at risk of developing anxiety and depression than those without PCOS. In terms of disordered eating, people with PCOS have increased odds of developing it. There's also an increased risk of binge eating disorder and bulimia in people with PCOS. And the features of PCOS can often have a negative impact on body image. And just a little tip here is that I've mentioned a few times that magnesium can often be low, and you can get magnesium in some of these foods here, like soy and peanuts, but it can help with mood as well. So it's an important one to make sure that you're having in PCOS. So what is really important and what is great is that it's now in these guidelines is about advocating for weight inclusive care and PCOS, and there is quite a big section in this report as well, which is really good to see. So in terms of advocating for yourself, or whether you have a child, for example, with PCOS, it is really important, and I think it's important to be aware of these guidelines as well, so that you can advocate for yourself and what your practitioner should be doing or not doing for you. So the guideline update says that practitioners should be aware of their weight biases and the impact that this has on their professional practice and on women with PCOS, and that being aware of weight inclusive practices which promote acceptance of respect for body size diversity and focus on improvement of health behaviors and health outcomes for people of all sizes, which I love. And so what this means for you is that your healthcare practitioner for you should be acknowledging that whilst a higher weight can be a risk factor for PCOS, it's only one indicator of health, and they should be looking at broader factors. Asking your permission to discuss and measure your weight, and using strategies to minimize discomfort if this does make you uncomfortable. So for example, blind weighing, where you don't necessarily have to look if they really need to take a weight from you. And I guess just questioning whether they actually do need to weigh you in the first instance as well. Obviously they will in some situations, but they don't need to in every situation. Recognizing that the terms overweight, obese, and obesity can be really stigmatizing, and using other language like higher weight. And that kind of, I think, goes nicely with this point at the bottom as well, increasing awareness of weight stigma among family members of women or adolescents with PCOS as well. So if you have got a daughter or family members who have got PCOS, we also know that it's a lot harder for people with PCOS to lose weight as well. So it's really unhelpful to use stigmatizing language. So we want to be weight inclusive and just be mindful with the language that we are using around children and our friends even. And again, I think that comes down to not commenting on people's body sizes as well, even amongst your friends. And then the option of offering weight-centric care, promoting weight loss, or weight-inclusive care, where we promote healthy lifestyle change without focusing on intentional weight loss, which is more of my ethos, and tailoring it to individual goals. And then offering all women support, regardless of their weight. So that's that one. So you can see I'm very happy about that one. And in terms of the kind of non-weight centric management, there are these principles of intuitive eating, which you may or may have not have heard of, but there is a lot of emerging research now in terms of intuitive eating and its benefits on PCOS or mindful eating. So these are the principles. It was coined by two dietitians back in the 90s. And yeah, as I said, there is lots and lots of emerging research coming out in this within this area, which is really promising. And as we touched on, it is really common for people with PCOS to have some kind of degree of disordered eating. So I do think that this can be beneficial for lots of women in terms of kind of ditching the diets and kind of working through these different principles. So that is definitely an area that I specialize in, and it's not necessarily a quick fix. It kind of is about a lot of unpacking of years of what diet culture has told us, but I do think that it can be very beneficial for people with PCOS. So specifically looking at movement then, again, just going back to the guidelines, they are also suggesting that there isn't one specific type of exercise that will be superior to another in PCOS, which again, I think is really important. Obviously, we mentioned about yoga and weight training being specifically beneficial in terms of reducing the hyperandrogenism. However, any kind of physical activity whatsoever is just going to benefit your health, help with those symptoms short term, and then help to reduce those long-term associated risks as well. So things like the type 2 diabetes. And the main thing is that it's sustainable and that you enjoy it. Otherwise, if it's grueling, like you're just not going to stick to it. And so they say that any physical activity is better than none. And it's just really important to limit the amount of time that you spend being sedentary. So many of us do work from home or do desk jobs as well, and it is so hard because I'm so guilty of it, but it's really important to just try and get up every so often and move as well, rather than just being sat there all day. And it can be useful after something like lunch or something as well, just to go for a bit of a walk as well, in terms of helping to kind of with firstly with digestion, but also in terms of the glucose absorption. In terms of prevention of weight gain and maintenance of health, their recommendations are to aim for a minimum of 150 to 300 minutes of moderate intensity activities, or a combination of 75 to 150 minutes of vigorous intensity aerobic activity per week, plus muscle strengthening activities on 2 non-consecutive days per week. They have some recommendations for weight loss and prevention of weight regain, which they say to aim for 250 minutes per week of moderate intensity activities or 150 minutes per week of vigorous intensities, again with the muscle strengthening activities onto non-consecutive days that week. And then in terms of adolescents, the advice is to aim for at least 60 minutes of moderate to vigorous intensity physical activity per day. And again, activities that strengthen muscle and bone 3 times per week. So just looking at kind of the whole picture as well, we know that sleep and stress can have a knock-on effect to symptoms associated with PCOS as well. So just looking at stress firstly, so stress can really affect the hormonal pathway. So for example, elevating your testosterone levels, but also have an effect on cortisol, which is your stress hormone. And it can have an impact on fertility, your cyst production, insulin sensitivity, and can exacerbate some of those symptoms that you might be experiencing. So tips in terms of stress management are things like talking to your friends and family, doing mindfulness practices, so things like meditation, yoga, journaling, or breath work, exercise and movement, taking rests where needed, potentially getting professional help from a trained therapist, body image and self-esteem work as well, and unfollow people on social media who don't make you feel good. And PCOS and sleep disturbances. So there is quite a link actually. And I definitely do notice this as well out of the clients that I see, that it tends to be the people with PCOS who more often will say to me, oh, I have like less than 7 hours per night. And when you speak to them, it's not necessarily like down to a job or anything like that. It just is coming down to sleep disturbances. And the problem with having a lack of sleep, as I'm sure you probably are aware if you're not a very good sleeper, is that it can have a knock-on effect to your hormones. So it can disrupt your appetite hormones, and then which can kind of dictate which you then end up eating the next day. So you might be more likely to opt for those high GI carbohydrates, but also can then have an impact on your blood sugar levels as well. And there's also a higher prevalence of obstructive sleep apnea and PCOS, and that's independent of BMI. So I think it's something to be aware of as well. So if your partner had said to you, you're snoring a lot, or you feel like you're super tired in the daytime, waking up with headaches, things like that, those are all symptoms of obstructive sleep apnea, and could be worthwhile just getting it checked out from your GP. But in terms of kind of general recommendations, I do think that it's very difficult to try and, this should say sleep here, not stress. It can be really difficult because I think for a lot of people, they've tried everything, but general recommendations are that we want to aim for 7 to 9 hours of sleep per night, avoiding things like blue lights before bed that we get from like our laptops and our phone, which obviously so many of us are guilty of, avoiding caffeine after midday, taking a hot bath before bed because it can help to rise your temperature and then drop so that it's nice and cool once you're in bed. And if you do have regular cycles as well, in the second half of your cycle, when progesterone is higher, it will raise your body temperature. So if you have got regular cycles, have a think in that second half of your cycle if you do feel like your sleep is worse within that time, because it may be that you might need to like cool the room a little bit more in the second half of your cycle, just as I say, because your temperature can rise after ovulation. Reading before bed, and then also doing a mind dump before bed. So fertility and pregnancy in PCOS. So people with PCOS will go on to have the same amount of children as those without PCOS. It's just that it might take longer to conceive, and that's if you're having irregular cycles. So in the first instance, if you are having irregular cycles, then make sure that you go and get it checked out. Make sure that you're tracking them so that we know how long they are, how many you're having per year as well. Especially, like I said, it can help in terms of diagnosis. And then obviously looking at implementing kind of dietary and lifestyle changes as well that could help to regulate your cycles. Then thinking about optimizing your preconception health, so thinking about taking preconception supplements prior to conception, so around 3 months before you actively start trying to conceive, so particularly focusing on folic acid and vitamin D. But with PCOS, like I said many times, you can have be more susceptible to having micronutrient deficiencies, so it might be worthwhile taking a preconception supplement so you're kind of covered with all of those micronutrients. Keeping caffeine at under 200 milligrams a day. And also it's really important for your partner to optimize their diet as well. So, if you're in a heterosexual couple, it's, half of your genetics. So it's really important for your male partner to make sure that they're optimizing their diet as well, and potentially going about and investigating their own symptoms as well. So, or having sperm analysis, for example, just to kind of rule that out as well if you are struggling to conceive. And you can do that via the GP more often when you're kind of nearing that 12-month mark of actively trying to conceive. And then the most common fertility treatment in terms of PCOS is ovulation induction. So you may have heard of letrozole or Clomid. So generally speaking, if you are having very long cycles or not ovulating regularly, then this is what would be recommended to you if there wasn't anything else going on in terms of like male factor infertility. It's a lot less invasive than something like IVF, and it's a lot cheaper. Generally, they might try doctor might try it with you for around 6 months and see if your cycles start to regulate. If not, then you might be looking at kind of a little bit more invasive fertility treatment like IVF. In terms of pregnancy, there are some increased risks and associations with PCOS. So just thinking about hypertension, so high blood pressure during pregnancy is more common in those with PCOS. People with PCOS also have a higher chance of developing preeclampsia during pregnancy. Again, there's a higher risk of gestational diabetes in those with PCOS during pregnancy. And unfortunately, if you do develop gestational diabetes, it can greatly increase your risk of developing type 2 diabetes later on. C-sections may be more common, and preterm births. And also, unfortunately, miscarriages 3 times more likely to occur in someone with PCOS, potentially down to the fact that more people may have been through fertility treatment, and perhaps the increase in maternal age if they have been actively trying to conceive for some time. So in terms of what you can do, if you haven't taken a fertility test and you're suspecting that you've got PCOS, or you already have PCOS and you just want to check in on your hormones, then as we discussed at the beginning, you can test each of these hormones and just kind of see how things are doing, and you will get insights from your report as well, tailored to you specifically. We test a whole panel of hormones, and something I didn't mention earlier as well, but if you have PCOS, you are more susceptible to having a thyroid disorder, and it's really important to have your thyroid or your thyroid stimulating hormone under control whilst trying to conceive. So again, you would be able to get insights into that, and we can screen up to 18 health conditions via the blood test. We do have lots of clinical services, so you can speak to any of our doctors after you receive your results. You can speak to our hormone and fertility advisors. We have registered nutritionists and dietitians, and we have fertility counselors. We also have scanning clinics that we can refer you on to if you've had a indication of being needing to be referred to a scan, and we also have fertility clinic partners. This is me and Olivia. So we both offer 1-hour nutrition consultations. Olivia is a registered dietitian, and as I said, I'm a registered nutritionist. These are kind of the specialities between us. I actually am 9 months pregnant, so I'm about to go on mat leave, so you won't be able to book in with me for a long time, but if you want to book, you would be booking in with the very capable and lovely Olivia, who is very specialist within her field. So yeah, you'd still be able to book, just not with me for a little while. So where you can find us is hertilityhealth.com. We have a Facebook page, Instagram page, hertility_health. I'm at the Nutritionist on Instagram. And then you can also contact us if you have any questions, info@hertilityhealth.com. But I know we don't have long left, so I will start looking at some questions. Somebody said, can PCOS develop into endometriosis, or is it common to have both? So you can have both, unfortunately, but PCOS wouldn't develop into endometriosis. They are two entirely separate reproductive health conditions. So can you have a long cycle and not have PCOS? Yeah, so potentially you could, because there are different causes of having irregular cycles. So I guess it would depend on the collection of symptoms. So if you had polycystic ovaries that was either detected in the AMH test or on an ultrasound scan, or if you had hyperandrogenism, either biochemical or physical symptoms. So if you had any of those other symptoms associated with it, then potentially it'd be looking like you have a PCOS diagnosis. But you can have each of those things in terms of the diagnostic criteria without having PCOS. You can have polycystic ovaries and not have polycystic ovary syndrome. And that definitely confuses a lot of people. Also with polycystic ovaries, it doesn't mean that you have cysts. So hopefully they will change the name of PCOS at some point, because it's really confusing. But cysts, ovarian cysts, are different to those follicles on the ovaries. But yes, in short, to answer that question. But like I said, there are different causes of having irregular cycles. So it's definitely worth exploring, because even things like lifestyle factors can cause irregular periods. So things like stress, over-exercising and under-fueling. I have been diagnosed with PCOS and I do suffer with irregular periods. I had no period last year and only one this year. What could you suggest I do to help regulate my periods? I really hope that I've answered that question now. This was asked quite early on, so fingers crossed you have some insights now into that. But obviously we discussed quite a few different things in terms of lifestyle factors and diet and supplements. If I get an AMH test, will that be sufficient to tell me how fertile I am? Will this test be able to tell me the quality of my eggs, or how would I get access to that sort of information? I'm trying to identify the best route to go via Hertility. Yeah, so when we interpret your egg reserve, we are looking at your AMH, but we also look at it in context of your other hormones. So we're looking specifically at the AMH, which refers to the quantity of your eggs, but we also look at your follicle stimulating hormone, your luteinizing hormone, and your estradiol. So depending on what those results come back with, it can give us insights into whether your ovarian reserve is considered within range, or whether it's considered kind of declining a little bit faster than what it should be, or whether you've got like a really good egg reserve. In terms of quality, there isn't a test that we can do for quality. So if you're under the age of 35, it's likely that you will have excellent quality eggs. So it's not until after the age of 35 that the quality of your eggs starts to decline. And that's when success rates in terms of natural conception, but also fertility treatments start to decline, just because we will then have fewer quantity and quality of eggs. And a hormone test is one part of the puzzle. So in terms of AMH, if you wanted to confirm your egg reserve, then you would have an AMH test with those cycling hormones that I spoke about, which we can test at Hertility. And then if you wanted to explore that further, if you were seriously, wanted to confirm your egg reserve, or if you were thinking about fertility treatment or something like egg freezing, then you would want to have an actual follicle count, which is where we count how many eggs there are, or how many follicles there are within your ovaries via ultrasound scan. Can PCOS be diagnosed at any age? Yes, good question. It can do, but like I was saying, in adolescence is a bit more difficult. And it depends on if you have got symptoms of PCOS when you're younger, then they would it may be that they kind of tell you to come back and they reassess in a few years' time. But also, yeah, you could be diagnosed in your 30s, and lots of people are, because there's a lot more awareness around it now, and there are tests out there like Hertility, so we are able to pick up and diagnose PCOS a lot more regularly now. Somebody asked about two people have asked about multivitamins, what brands would I suggest? So I can't specifically recommend a brand. Somebody asked about where would you get inositol from? You can get inositol pretty much from anywhere online. With inositol, you want to go for the form that mimics how it naturally occurs within the body. So either myo-inositol as a standalone supplement, or you can get myo to d-chiro-inositol at a ratio of 40:1 of myo to d-chiro. You will find it everywhere online now. And like I said, some of them come with chromium in them. If you Google PCOS supplements, inositol will come up immediately. I'm aware that we're across past 9 now. Okay, I guess we should probably wrap this up. I know there's quite a few questions still. I hope that I've answered a lot of these now, though. Any different levels of PCOS depending on symptoms? So hopefully I did speak about that at the start as well, about the different phenotypes as well, and that it just depends on the collection of symptoms that you have. So we don't really have different levels. Yeah, we more refer to them as the phenotypes. So whether you've got acne and missing menstrual cycles. Okay, so there are still quite a lot of questions. And a lot of them are really specific, and I can't answer specific medical questions. But hopefully, I hope that now I have answered a lot of these questions that were asked a lot earlier on as well. Is ultrasound necessary to diagnose every type of PCOS, or PCOS can be diagnosed without ultrasound scan? So yeah, so now, due to the new guidelines, the guidelines are suggesting that off of an AMH test, we can diagnose polycystic ovaries. So again, you can do that via Hertility. It may just be that there's another clinical indication as to why you might need to have an ultrasound scan. But yeah, we now can use AMH as a tool for diagnosing polycystic ovaries. Is it best to remove alcohol completely with PCOS? I think in general, alcohol isn't great for our health, no matter what condition we have, or even if we don't have any conditions. I think specifically when we're thinking about preconception, it's really important to think about minimizing alcohol, or if not completely abstaining whilst in that preconception period. So kind of the 3 to 4 months prior to conception. And definitely whilst trying to conceive as well. But you have to be realistic as well. For some people, it can take, up to 12 months to conceive. And for some people, especially with PCOS and irregular cycles, even longer as well. So I think we have to be realistic, but we know that it can have a negative effect on egg quality, likewise with sperm health as well. And just in terms of thinking about, because you do have like this low grade chronic inflammation with PCOS, alcohol can exacerbate that, and it can also disrupt your hormones as well. So things like the luteinizing hormone, follicle stimulating hormone, testosterone as well. So in an ideal world, I guess none of us would drink, but we don't live in an ideal world. So if you could cut down, if you were a big drinker, then it would definitely benefit your health for sure, and benefit your PCOS. Is there a certain age bracket to conceive by if you have PCOS? I think, like I said, it can take slightly longer if you have PCOS to conceive, especially if you're, when you're at a disadvantage, when you're not having 12 cycles per year, when somebody has got 28-day long cycles. So definitely at a disadvantage in that respect. So I'd say if you are thinking about it, then, you know, it's a good idea to start trying to implement these lifestyle changes sooner rather than later, especially if you're having irregular cycles as well, just to see if you can find something that works for you, because that's going to kind of be the biggest factor in terms of you know, inhibiting you being able to get pregnant naturally. And then I guess just knowing your options out there as well. So obviously we spoke about things like ovulation induction as well, but in terms of age bracket, like I said, it kind of comes down to the egg quality, which we know declines after the age of 35. So again, in an ideal world, we would be trying to conceive prior to the age of 35, before the quality of our egg starts to decline, because after that age of 35, your risk of things like miscarriage and implantation failure does start to increase, just because the eggs are more likely to be chromosomally abnormal. So I guess it's kind of the same for everyone in that respect. You know, all of our egg quality is going to be affected after that time. However, like I said, if you already know that you've got issues with, you know, your menstrual cycles not being regular, then it's good to be proactive and kind of look into that sooner rather than later. I hope that helps. And there's a lot of questions there, so I mean, feel free to get back in touch if you know, I missed anything specifically. And obviously, if anybody wants to book a one-to-one nutrition session, then you can book that through the Hertility website as well. But I hope this was helpful. Thank you so much, everyone, for joining. As I said, it's recorded, so you can always refer back to it if you have missed some of the presentation. And I think we'll get it emailed out to you. But yeah, thank you so much for joining me this evening.